today. I hope you're excited to be a participant in this presentation. We have some great speakers that have some great subject matter to go over with you. And I want to welcome them, welcome Lisa and Margaret, and to also acknowledge support and sponsorship from Parker. We thank Parker for their continued support, without which we couldn't put on events such as this. So again, thank you to all involved. Thank you to Meagan Glaser from LeadingAge as well. I will step aside as my words are not nearly as important as those that you will hear from the speakers. So thank you again for participating. I'm happy to have introduced you all to the session. Have a wonderful session.
Thank you, Steve.
Thank you.
And now we will turn over to Margaret from Parker, for whom we are very grateful as the sponsor. Margaret.
Thank you so much. Good morning, everyone. We are very proud and happy to be sponsoring this innovation series. And I just want to go through very quickly about Parker. If anyone is not familiar, who is Parker, our mission, vision, and the services we offer, all of them in central New Jersey. So someplace near you, I believe. Next. Okay, so Parker has been here in originally New Brunswick, offering services since 1907, and with a little nursing home right on Eastern Avenue in New Brunswick. And now for over 100 years, for over a century, we have been growing and servicing older Americans in here. The last couple of years, we are really have grown exponentially, and I'd like to share with you some of the exciting things we have to offer. Next. Okay, so our vision is actually, we make aging part of life. It became during a couple of years ago when we did the branding, it actually is a part of our tagline. It's part of our logo. That's how important we feel, how passionate we are about making for all of the people, especially our elders, aging part of life. And our mission is to discover ways to make aging manageable, relatable, and enriching for all of society. It's a really big one for all of society. I know that here in New Jersey, we're all passionate about the elders we serve in the New Jersey area, but our mission is expanding beyond those parts. And I think that you're going to see this innovation and this innovation series and everything we're going to hear in the next hour or two is going to really link us to this mission. Next. So one of the things, lots of things. So Francis E. Parker, for over a century, our name has been Francis E. Parker Home. We've also been known as Parker Home and many different things. His legacy has been, he was a very renowned attorney, mostly on Park Avenue, but he developed very early in his life incurable disease, and he was bedridden, requiring nursing around the clock. So next. So actually, one of the things that we really see is that he felt a lot of times he was saying, how do other people, so if you think about over a century ago when he was alive, who would be providing the care for someone who was bedridden for over 7 years? Next. So of course, it's his lovely wife, Henrietta. We are very pleased and great gratitude to her, because she was the founder, in memory of her beloved husband, She founded the home on Eastern Avenue, and her vision was to bring passion and comfort to those who needed it. Next. So she really started this legacy, and in 1907, she established this home. She also was very, very passionate about education, and this really ties us to that has been our North Star for over a century, because at that point, just like now, there was not enough of nurses to care for the people. Next. So we really feel that positioning Parker through vibrant leadership and partnerships with other providers is really something we are very, very part of life. Next. So our aging services, we really have on the right, if we look at it, we provide post-acute rehabilitation. So anyone coming in from the hospital, we have a lovely assisted living. We have 4 nursing homes with specialized memory care, and we have health and wellness. We also have Parker Navigator, which is a care services, a rehab at home, and 2 adult day centers, and respite care. Next. So where are we? So assisted living is Parker at Stonegate. It's located in Highland Park, right on River Road, where we also have Parker at River Road. So actually Parker at River Road is in Piscataway, but we're right on the border. And we also have, as I said before, Parker at Landing Lane, which is our legacy home located on Eastern Avenue in New Brunswick. And 6 years ago, we opened Parker at Monroe, a very unique community in Monroe Township. Parker at Somerset, we acquired 5 years ago, and that offers long-term care services and also post-acute rehab. And also that is our Medicaid home. So we accept Medicare and Medicaid elders over here. Where we have grown significantly is really home and community services. So outside of our brick and mortar of residential homes, we really have very, very vibrant adult day centers, both in Highland Park and Monroe Township, and opening soon in Somerset during our expansion. We have a health and wellness, including an aquatic center with heated pool, rehabilitation services, all of the therapies for people living in a community. We also offer that at home, rehab at home. And also we have a unique program of bringing our adult day to the independent senior, affordable senior houses in Piscataway, North Brunswick, and Somerset Township. And also with the Parker Navigator and Respite, which is offered at all of the residences. Next. Thank you, and I look forward to some of your questions at the end of the program.
Thank you very much, Margaret. We appreciate it. And again, we appreciate Parker's support. And now I'm going to turn this over to Meagan from LeadingAge, New Jersey and Delaware. Meagan.
Good morning. I just wanted to say thank you to Melissa and Sue and the New Jersey Advocates for Aging Well for organizing this important webinar series and inviting LeadingAge New Jersey, Delaware to participate today. I also wanted to thank Margaret and Parker, which is a long-standing valued member of our association, for making education sessions like this possible. And of course, the star of the show, Lisa, who will speak to you shortly about the unique PACE program that she runs. She's the Executive Director of Life St. Francis. Next slide. As Sue said earlier, my name is Meagan Glaser. I'm the Vice President of LeadingAge New Jersey, Delaware. As you can see on the slide, There are some images of my colleagues, Jim McCracken, who's the president and CEO, as well as Emily Beck, who's our membership and events associate. And then we have a whole team of consultants from emergency management to housing and regulatory affairs that all support our aging services providers. Next slide, please. In the interest of time, I'm not going to read through our entire mission, and I know that Sue's going to be sharing the slides with you after the webinar. But for those of you who aren't familiar with LeadingAge, which is our national affiliate, and LeadingAge New Jersey and Delaware, which is the state partner affiliate that I work for, we are a nonprofit association of aging services providers, and we all share a mission to help older adults thrive. Next slide, please. As you can see, LeadingAge members are mission driven. There are more than 5,000 nonprofits that all have come together to be part of the LeadingAge family. LeadingAge really represents a whole continuum of care. So everything from skilled nursing facilities to assisted living, CCRCs. As Margaret mentioned earlier, we've really expanded our membership as well in terms of home and community-based services. So home health and hospice. Here in New Jersey, more than half of our membership is actually senior affordable housing communities. And today, if you look at the slide in the upper left corner, the house with the heart, we're here today to talk about PACE, which is an incredibly unique and innovative program, which is why it's so great to focus on that topic today in this series. There are 38 state partners that belong to LeadingAge, and then we have hundreds of business partners that have all come together to help support our aging services providers and research partners, as well as foundations. Next slide, please. So some of the things that we provide for our members are included. Next slide. There you go. Some of them are included on this slide. So my background is actually, I have more than a decade of experience in policy and advocacy. And that's something that we feel very strongly about and make sure that we provide to our members. So we track legislation at both the federal and state level. We are often mobilizing our providers to speak at various legislative hearings in Trenton, as well as to Congress and our federal delegation on Capitol Hill. Education, we provide year-round education for our members. You know, lots of folks need certain CEUs to maintain their licenses, but we feel that it's really important to maintain you know, learning and education throughout the year. Our annual conference is typically in Atlantic City, but we had to pivot to a virtual platform due to the pandemic this past October. And we are joining forces with LeadingAge Pennsylvania this year, so it's going to be even bigger and better. And it really, once again, we provide education for the whole aging services continuum, and that'll be June 15th through the 17th. In terms of information and news, many of you on the line today, if you are familiar with our organization, probably receive our daily newsletter, which synthesizes and compiles a whole host of information, everything from news articles that are relevant to the aging services industry to new regulatory guidance that our members need to be aware of to be compliant and to continue to provide quality care for their residents. We also have a COVID resource hub on our website. Networking, we typically would have a golf outing as well as an awards program. Our awards program, we did just host that last month with over 100 healthcare and housing heroes that were on for that program. And it's really an opportunity for us to all gather in fellowship to celebrate the excellence and the hard work that our folks are providing on the front lines every day. In terms of what we've done to be responsive, which I think Lisa will talk a little bit about how her program's been responsive to the pandemic, we've really shifted a lot of the networking to an online platform so members can pose questions with one another, share best practices, different policies. We host a number of roundtable and committee meetings on Zoom. So really give folks the opportunity to continue to network within the field. And then there's group purchasing down here. You'll see on the slide for Value First. There, we work very closely with different research institutions to provide resources and tools to our members. And then there's just a whole host of on-demand education that we provide as well. Next slide, please. So as you can see here, you know, once again, LeadingAge really representing the whole continuum of care. And I think what's so important here is that the landscape of aging services is really changing. So it's more important than ever to have a multi-specialty focus, to be interdisciplinary, which is once again why I think it's such a great topic for discussion today is PACE, because I think PACE really embodies those values. Next slide. This is just the list. I'm not going to read them off, but just so you get an idea, over 142 members belong to LeadingAge New Jersey, Delaware, and here are some of the few listed here. Next slide. And I know Sue has asked that folks hold questions to the end. I will be moderating the chat. So if you have any questions for me or Margaret, Sue, and then of course Lisa, please feel free to put those in there. And then of course, these are our social media platforms. We'd love it if you'd follow us on Facebook, Twitter, and LinkedIn. And you can always contact me at that email address and phone number if you have additional questions. And at this point, without further ado, I'll turn it over to Lisa to talk about PACE.
Excellent. Thank you so much. Thank you to New Jersey Advocates for Aging Well, and also Parker. And I also want to thank Meagan. We've been working over a year now, and it's been a great collaboration. And I very much appreciate the support that I've been receiving from LeadingAge New Jersey, Delaware. But without further ado, I really hope today to be able to share with you not just words on slides to speak about what PACE is, but I'm hoping to be able to share some real life examples to be able to drive home specifically what we do and the level of, I'm going to use the word intimacy in which we do it. Sometimes we are the only family that our participants have. We are a program that supports participants as well as caregivers. We'll talk about the fact that we're an insurance option under Medicaid. And I hope that we have, or you have the ability to think about maybe how, if you have a PACE program in your area, that there could be further collaboration and discussion. So I'm hoping that for many of you, if this is an introductory course or presentation to PACE, that you really have an appreciation for what it is that we do. And if you're somebody who is familiar with PACE, hopefully you'll be able to pick up a couple of the innovative ways that we do provide care coordination throughout the continuum. And when I say throughout the continuum, I think that is something that sets PACE apart from other managed care options. We really bring participants into the program, and very often we're with them throughout their life. Our goal is really to help them die in the home setting. And that's the whole goal of PACE, to keep our participants safe and healthy, living in the homes that they love as long as possible. So I am going to be sharing some real life examples with you. So I'll be reading a little bit. So before I get started on some of the slides, I wanted to talk about an article that three sisters had written along with Life, and I'll call her participant G. So G had battled a mental illness disorder throughout her life. It took a toll on her, and it pushed her three sisters to their limit trying to get access to the care she needed. She had a number of doctors, but they were all disconnected. They didn't communicate well with one another. We knew her medications were taking a toll on her, and the lack of communication led to ongoing, life-threatening medical situations that landed G in the hospital a number of times. It was an incredibly difficult situation. The sisters diligently worked to get G back on her feet after each hospitalization, only to have a repeat occurrence months later. We really thought we were going to lose her on several occasions. We worried about her all the time. We'd take turns going to her apartment, managing her prescriptions, driving her to the appointments, and just trying to provide her with whatever she needed. It was in March 2019, while G was regaining her strength at a rehab center following another hospitalization, that the sisters learned about Life St. Francis. I immediately met with the Life St. Francis intake coordinator. She was wonderful at getting G the help she needed. She acted quickly, and we didn't have to wait for anything. She was so compassionate and understanding. I can't put into words what a relief it was to find Life St. Francis. Life has specialists in all different areas, and they communicate with each other. They respond whenever we call them, and they listen to our concerns. It's a true team approach, and no detail is overlooked. The change has been remarkable. G is independent and happy. She's a brand new person. She's painting, cooking, decorating her apartment, doing puzzles, and cooking for herself. It's a miracle that we learned about life. We didn't realize how good this would be for our sister. Life St. Francis has been a relief for us and has given G her life back. And that's a common story that we hear all the time. Another one, this is a woman who had a pretty significant stroke when she was 54, and she became really full-time care. She joined the program 9 to 10 years ago. She just recently passed away. But her spouse was able to bring her home from a nursing home instead of her staying there for the rest of her days. And with our program and our support and services, he was able to care for her at home. And he said we would not have had a life if it weren't for life. So those are just two examples just to start my presentation. We have two Trinity Health life PACE programs in the state of New Jersey. And just for Life St. Francis, we are a subsidiary corporation under St. Francis Medical Center. I've had the pleasure of working with St. Francis for over 30 years. I joined the PACE program in 2012. And really, in everything that I've done in my career, I feel like PACE is really the culmination of everything that I've ever done. And although the days are difficult, the joy that it brings is really pretty astounding. So we can move to the next slide. Thank you. So we're going to cover the overview of the PACE model, how we differ from other managed care models and add quality and value. Certainly, I'd like to really be able to drive home how we coordinate care and how that's different from how the managed care companies may coordinate care. And certainly how we collaborate and communicate with one another, and also many of our providers, families, participants, and whatnot. And then I welcome questions, so make sure you're putting questions in the chat room. So PACE stands for Program of All-Inclusive Care for the Elderly. It is an innovative program. It started years ago, back in the 1970s in San Francisco, with a program called Unlock. You can always Google Unlock to just find out how the basis for the program having started. We do provide a coordinated and integrated care approach by a team of healthcare experts. You'll hear me talk about our interdisciplinary team. The interdisciplinary team is really at the hub and the core of what it is that we do. So we'll talk about that in great detail. And our whole goal really is to keep seniors living independent and safe as long as they can in the community surrounded by our services. And, you know, when we're talking about safety, we're not just talking about, you know, an environmental type of safety. It's whether they're having difficulty taking their medications, and maybe they're not taking their medications. Maybe they are falling a lot at home. Maybe they're having many hospitalizations. So, you know, we define what safe is for them, and we develop a very active and fluid care plan, all focused on making sure that our services will help them, you know, achieve the goals that they would like. We are capitated by Medicare and Medicaid. So to be in the program, you at least have to have the Medicaid option, or at least the ability to pay for Medicaid. We are about 85% dual, meaning you have both Medicare and Medicaid. And we do have just a very small handful, maybe 4 participants that have private pay the premium for Medicaid. That is it. I mean, that's why it's so important, because those are our capitated dollars that we receive. We're on a smaller program. We're not large like the insurance companies are. So it's very important for us to be able to make sure that our teams are, doing medical necessities reviews and assessments, and really making sure that the care plan is always being adjusted to meet a participant's care needs. Move on to the next slide. So I think what makes us unique is that we're both the provider and the payer. I know it gets very confusing when we have a participant in the hospital. They really look at us as a nuisance, because we are the one, because we provide the in-home services or really facilitate the discharge plan. So we need to have conversations, but we're also the insurance company. It does get confusing, and I think people don't always understand that little innuendo about the PACE program. We're definitely a long-term care alternative under MLTSS. Our goal is really to make sure that we can keep people in the community as long as possible. Right now, we have about 91% of our participants that do live in the community. We have about 25 participants who do live in the long-term care setting. But our goal really is to have them live in the community at the outset and just elongate that as long as possible. In our program, you're dealing with a lot of family dynamics. Oftentimes family partner with us with caregiving, and sometimes they'll just pull out of the case, and we have to figure out how we're going to keep somebody safe in the community so that we can elongate and avoid that nursing home placement as long as possible. We are licensed as a unique provider by New Jersey Department of Health. The day center provides services such as health and personal rehab. We have recreation, and the recreation that we provide in the center it's certainly fun. They have a great time, but a lot of it is also ability focused. So if we have participants in wheelchairs, we might do volleyball, seated chair volleyball, because then they're moving and they're exercising. We do a lot of work with trivia. We have computer programs. Basically we can meet all of the needs with different cognitive levels of our participants. So there are times that we bring socialization like bands in, or comedians, whatever the case may be, but we really with our recreation therapists are very driven to make sure that recreation is ability focused. The center really is an intervention. It's really the place where all of your care providers are under one roof. So whether you're coming here for an appointment, for rehabilitation, for a day center day, this is where your social worker can meet with you, your physical therapist can meet with you. Maybe you're going to see your primary care provider. This is the place where we get to lay eyes on our participants, and that is one of the unique differences, because we do have this day center. We can, because we know our participants, we can detect very minor changes in cognition. So for example, our home health aides, we have a tool that they use, and our frontline home health aides and transportation aides are very critical to a PACE program, because most often they are the team that are seeing the participants the most, and they can determine if maybe there's tripping hazards in the home that they need to report. Maybe somebody seems a little more confused. 9 times out of 10, if somebody who is elderly is confused, there may be a urinary tract infection brewing that can lead to issues, hospitalizations, ER visits, and whatnot. And that's no different for the aides that we have in the center as well. Everybody is trained at all levels to be observant. And just by the nature of the fact that we build relationships in this model to the extent that we do, they get to know families and they get to know participants, so they can alert the team if anything needs to change or be addressed. There are 6 PACE programs in the state of New Jersey. We are located in Bordentown, New Jersey. The other Trinity Health Life PACE New Jersey program is located in Pennsauken. We have a program in Jersey City, Lutheran Senior Services, and Spirit Life is south of the state. Beacon Health and Social Services is in Oceanport, and Atlantic Life Connection is in Atlantic County. And one of the things that I will point out just with this slide, PACE is not in every county throughout the state. And I think that that is a challenge because not everybody who is eligible has access to PACE throughout the state. We do a lot of advocacy and a lot of education of representatives in the legislature, and I think we're going to be doing something with the Senate in the near future. But in any event, we really do try to work with the state to help them understand the value of PACE so that we can enhance this or make it available to more participants throughout the state. You can go to the next slide. So how do you become eligible to be in PACE? You have to be 55 or older. You have to live in your service area. So for example, Life St. Francis covers all of Mercer County and parts of northern Burlington. You have to meet a New Jersey nursing home level of care. So we have a nurse who is actually trained and certified to do these level of care authorizations. So she will actually visit participants in their homes before they're enrolled in the program and determine whether or not they do meet the qualification for being in a nursing home. You also have to determine if somebody can live safely in the community at the time of enrollment with PACE services. So that's a challenge. You know, also with enrolling participants in the program, because the managed care companies, anybody can enroll, but in PACE, you have to actually meet eligibility criteria. You can move on to the next slide. What is unique about PACE? So we are committed to the whole promoting optimum independence in the least restrictive setting, typically is their homes. You know, there is, with my staff, they struggle sometimes with the fact that, you know, the participants, even though they're enrolled in our program, this is a very autonomous program, and we do promote their independence. So sometimes there may be, they may be a fall risk. They may not use assistive devices. There may be concerns about the type of home that they're going to. We try to mitigate those risks to the extent possible. But, you know, these are people who are of sound mind that can make their own independent decisions. And that's what's so challenging for the team oftentimes, because once they get into that home setting, if they're choosing not to use their walker, we really have to try to make sure that maybe we're enhancing oversight. Maybe we're increasing home health aide hours to provide additional support. Maybe we're putting in the emergency response system. Maybe we need to put grab bars in the bathroom. That's the fluidity of the program and how we can adjust care plans as needs change. When you have somebody who maybe had a fall and broke a hip, that could change the course of their life in an instant. They go into the hospital, then they do rehab, and then going home, if they really don't come out of it well and they need assistance, then that changes the care plan. And we have that ability to make those adjustments throughout the continuum as needed. And I mentioned, we're responsible for the participants' care across all settings through the end of life or disenrollment. So we have contracts. We have a very small network of nursing homes that we work with. We have specialists. We have one specialist actually in each of the disciplines. So we keep our network very small. And the purpose of that is because we really do pride ourselves on our care coordination and communication with all of these providers. That's really what we excel at. And so, you know, our providers understand the program. They don't feel as though somebody's imposing when we're asking questions. It's much more of a collaborative relationship. We have the flexibility to provide the right care at the right time in the right setting without any restrictions. So I know with Medicare, you have to be in the hospital several nights before maybe you can go to a rehab. We're the insurance company, so we don't have that rule. If we have somebody who maybe breaks a pelvis, goes to the emergency room, we don't have to admit them. We will get them placed into one of our contracted nursing facilities where they can rehab there directly and recover. So that's the nice thing, that we can determine what the services are. If somebody's coming out of the hospital, and I call it the traditional managed care, and they need home care, we're not limited to just a couple of weeks, like 1 or 2 times a week. We will provide the home care that they need for as long as they need it until we feel that they are at a point where they can, be living independently and safely. And we focus on prevention and health maintenance to reduce emergent care utilization. I mean, we all know that hospitals are not the best place for the elderly to be. Anything can happen, infections, and it's disorienting. And it's just they're out of their homes. Our elderly love being in their homes, so that we really focus a lot on education to call our program first. We have access to their medical information. We oftentimes will have conversations with emergency room physicians, providing information and oftentimes reassurance that we can coordinate the care and assure that somebody's going to receive the care that they need without having to admit them to the hospital. You can go to the next slide. Oh, I did want to say one other thing about the last slide. You don't have to go back, but we focus on disease management. Our number one diagnosis here at Life St. Francis is congestive heart failure. Our second most significant diagnosis is mental health, behavioral health, if that just gives you an idea as to what's going on in the community. But we actually have case managers and our entire team who focuses on an algorithm with congestive heart failure with diabetes, with COPD. So our goal really from a disease management standpoint is to try to make sure that people are not, that it's not getting out of hand. So for example, change of season, we make sure that they have their air conditioners. We make sure that, our home care nurses are going in, they're getting weighed. We're bringing them to the clinic. Maybe, as their congestive heart failure is advancing, we're going to increase their visits to a weekly visit. That's not always easy for somebody under another program. They're arranging transportation. We arrange all of the transportation, so we can make that type of, sequencing with the visits possible in this program. We do, I mentioned that we're all-inclusive care. What does that mean? So I employ geriatricians, nurses, nurse practitioners, physical therapists, occupational therapists, dietitians, social workers, home health aides. We have 13 vans out on the road, so we employ transportation aides and drivers. If anybody in the healthcare team is actually a part of this program. When somebody comes into the program, they really have zero out-of-pocket costs. That's the all-inclusive care. It's from a payment perspective as well as a care perspective. If they need the grab bars in the shower, if they need a walker, that's all part of what we provide. We pay claims to hospitals, we pay claims to the specialists. It's completely all-inclusive. We bear the full risk for all the services that are medically necessary. So that's why the team, they meet every day. Every PACE program I know, they have an interdisciplinary team that meets every day, and they're looking at care plans. They're talking about participants that maybe are back on the radar if they had some kind of an event. I know here every morning we have a standing 8:15 appointment or meeting, and our entire care team is on the line, and our RN overnight will actually give her report. So we're on call 24/7, 365 days a year. And then we go into care plans. Where the services are, I talked a lot about the care team and the contracted provider network. When we do care plans, if we have somebody in a nursing home, they are on the line with us and they're part of the care planning process. And also with our participants, they need to be part of the care plan. So even after we develop a care plan, we will present it to the participant, explain it, make sure that they feel that it's going to meet their goals. And if there's something that they need added or revised, then we'll bring it back to the team for review and consideration. We also establish goals of care. Do they want longevity? Do they want to live forever? Is it functionality? We have so many participants that come into our program that are really having difficulty walking. They haven't really been out of the house, and they work with our outstanding rehab team. And before you know it, they're on a walker, and they're able to get out of the house and make short trips. Or maybe it's comfort care. Maybe you're like a little bit more towards the end of your life, or you just really don't want a lot of medical intervention, but you really want to have the care coordination and support from our team. And I mentioned that obviously care plans are individualized and customized to whatever our participants' needs are. Next slide. So I have, my medical director is a geriatrician. We have another full-time physician who is a geriatrician, and we have 3 nurse practitioners here who are all geriatric experts. That makes a difference. I mean, you can almost see that if they get into the hospital just wants to do everything. They want to do peg tubes when they're leaving the hospital. They want to do all kinds of things that just do not make sense, or are not sustainable. Our geriatricians are very tuned into the elderly and what makes the most sense to care for this population. I mentioned that our nurses and a primary care provider, they're on call 24/7 every day of the year. So we have an answering service. It's real-time response to whoever is calling, whether it be participants, family members, contractor providers, hospitals, whatever the case may be. And we're able to address whatever the concern is right then and there. I mentioned that we also are focused on preventing emergency room visits. So maybe if they just need to be talked down off the ledge if they're having an anxiety attack, or maybe we're able to have my on-call nurse or the next day a home care nurse go into the home in order to check them out and be able to address whatever the concern is. Or maybe we make an appointment to get them into our clinic first thing in the morning. So we would coordinate that with our transportation department. Whatever the oversight and follow-up is during off hours, we provide that. You can move on to the next slide. So I mentioned transportation a lot. I think that's really important because seniors really struggle. A lot of them aren't even capable of scheduling transportation. So I have a department that does that, and we can transport them to all of their medical appointments. We take them to the hospital or wherever they need to go for studies. We'll bring them home from the hospital. During the pandemic, our transportation team early on, they were just making care package deliveries and medication deliveries to our participants. They're an incredibly integral part of any PACE program. We have a contract with the pharmacy, so we provide all of the medications, whether they're prescribed or over the counter. We here are very focused on really reducing opioids, making sure we work closely with our pharmacy to do a lot of risk assessments to make sure that the medications that they are on are optimal medications. I'm not sure that that's really happening in a managed care setting, but we look at high-risk participants with long list of medications. Our whole goal is to try to reduce the number of medications to the extent possible. So we do a lot of adjusting in that area. Nursing care, we have wonderful nurses that have a lot of background and experience in our home care department as well as in our clinic. Personal care, we have the ability in the center to do personal care, showers, toileting, and also in the homes we provide that, the personal care that they need. As far as meals, our dietitians are great. They determine whether or not participants have breakfast, lunch, and snacks. It's been a challenge during the pandemic because we have a dining area here and provide breakfast and a hot lunch option and alternatives, and certainly snacks. But since we've been shut down, we've had to make sure that we through mom's meals, or every day we're sending out care packages or sending out boxed meals, frozen meals, whatever the case may be, to make sure that they have the food that they need. I talked about recreation therapy a lot in the beginning. We do a lot through crafts, and actually I had a testimonial from a family that actually said that we're saving their life. With the pandemic, this family member has been staying home with her mother who has dementia. And my recreation therapist is sending care packages out. We're doing remote recreation. So she's sending bingo out. She's sending crafts out. And she's sending out games and crafts that the daughter can do with this particular participant at home. And it's just been a lifesaver. She's just said that, her happiness has been immeasurable because she really feared the worst going into the pandemic. As far as rehab, we have a well-equipped rehabilitation suite. We have experienced physical and occupational therapists, and we also have a contracted speech therapist. Our social workers, I can't say enough about our social workers. In this program, because it's in the community setting, you're dealing with family dynamics, and family dynamics oftentimes really can either enhance or inhibit your ability to provide care. Sometimes the family scenarios create unsafe conditions. So this is a community where, our social workers are challenged every day. And when I had mentioned early on that we have the second diagnosis is behavioral health and mental health, it's really challenging making sure that we can connect them to the services that they need to be able to address their mental health needs. So our social workers are, part of, I have heroes that work here every day, and whether it was the pandemic or not, they go above and beyond every day. And we here at Life St. Francis also have a chaplain that provides pastoral care. She's been doing a lot of remote like masses. She'll do Bible studies. She's running support groups as well for our participants because it's mind, body, soul, and spirit. And it's a very all-encompassing approach. And I can't tell you how many times somebody might be having spiritual pain, and maybe the team is trying to develop something in the care plan and the participant is just not having it. We'll get our chaplain involved, and sometimes there's something just deep down inside that she's able to uncover and make headway with, that we can now execute and facilitate something in the care plan that the participant really needs. I do want to also say with our services, because we're the insurance company, we have back office functions. So we have a business office. We have a team that does scheduling. And that's the beauty here, that our schedulers are very busy because they are an integral part of what we do every day. We're always saying, if we get a phone call that somebody's not feeling well, we have to call the scheduler and have them schedule an appointment to see either a specialist, or they have to collaborate with the transportation aides. We have a participant who is always canceling her dialysis. And, the scheduler will say, wait a minute, because she's a part of the morning meetings to hear what's going on. And they will really tune into the fact, wait a minute, this person really needs to be scheduled to be seen here. And they'll alert somebody that somebody needs to be making a phone call and really encourage them to get to dialysis, or some other scenario like that. You can move to the next page. So the interdisciplinary team, heart and soul of what it is that we do here. We have all of the medical providers, including transportation. We have a representative from our home health aid department. We have our center manager who participates. Pretty much every discipline is represented in the interdisciplinary team. And this is the team that really determines the care and services. We do face-to-face assessments of our participants. If we have to go into homes to see if something's changed there, we'll do that. But this is the team that drives the care plan. We develop relationships with participants and their support network. So, like I said earlier on, this program is not just for the participant, it's for caregivers. I think that during the pandemic, so many people were working from home, and they were just so grateful that they had the support of the program to allow them to work, but also to, I guess, ease the burden of taking care of somebody. I talked about managing care across all settings. We do assessments of our participants every 6 months. And if we think that there is a change of status, maybe something significantly happened, then the team in the interim will also do another assessment. We will do that as often as it's necessary so that we can keep the care plan as up to date as possible. We also serve as the coordinator with contracted vendors. So any contracted vendor, we will make sure that we get the medical records. Our primary care providers may be having follow-up conversations. They'll bring information back to the team after doctor's appointments, and we make adjustments accordingly. You can go to the next slide. I already mentioned who everybody is on our team, and really at the core of it is the participant caregiver. I spoke early on about the 3 goals, the functional, longevity, and the comfort. We make sure that the care plan is developed around those goals. We share these care plans with the participant and the caregivers, and adjust it accordingly. You can move to the next slide. One of the challenges with PACE really is, how do we get the word out there? I mean, as I had mentioned, there's so many counties that are still uncovered with PACE, and we have to qualify our participants as well to come into the program. In managed care, participants just get enrolled into the insurance company, but for us, we have to rely on referrals. And it's really been so incredibly challenging throughout the pandemic, because so many of our referral sources have also been shut down. So we've been really struggling. And it's a complex program, and we rely on people, and maybe many of you who are listening today are in a position where you're thinking to yourself, well, wow, maybe there's some way that I can collaborate with the PACE program in my area and make referrals. I mean, that's really our, bread and butter, is relying on our partners and the collaboration with, people out in the community to spread the word. Senior housing is significant for any PACE program. More than likely, that's the population where, you will probably have people that would be eligible. We have very close working relationships with the security guards, with the building managers. If they're seeing somebody who's all of a sudden struggling to work or walk, maybe they're seeing them being taken out in an ambulance often. We work with them to help them, identify the things that would trigger maybe a referral to us. I think only people who work in PACE, our intake and enrollment team, are very skilled at presenting PACE. So it's really just working with the community and different organizations, housing in the community, family, friends, whatever, to understand the program and to just make the referral. It is, we get a lot of our referrals, believe it or not, just from our bands, because we do have our bands wrapped in the Life St. Francis logo. We rely on family and friends, on social media, anything that we can do with digital marketing, programs such as this. We've invested some funds for internet searches if people are looking for senior services. We actually have a plan to work with some of the politicians, but more importantly, like their receptionists that maybe are at the local level getting phone calls where we have potential participants or referrals reaching out looking for information. But that's a struggle. It's really getting it expanded throughout the state, and really trying to help educate people around PACE. And a lot of times it's those things that are less tangible that I try to convey and bring out with some of the stories and how we've been able to change lives. And there's another story, we've really become a part of a family. Last summer, and it was not COVID related, I had a home health aide who had taken care of a participant for many years. He took a turn for the worse. His goal was to die at home. And she was supposed to go on vacation, but when it seemed as though his death was imminent, she canceled her vacation to stay with the family and support the participant and his family until he passed. I mean, you don't find that everywhere. And that is the level of, I'm going to say, intimacy that we have with a lot of these families. And with our participants, sometimes we are the only socialization or people that they have in their world. We become their family. This past Thanksgiving, typically we would do a Thanksgiving dinner for everybody in the center, but we identified at least 60 of our participants that had nowhere to go, no family, and we were able to collaborate with St. Francis Medical Center and deliver fresh Thanksgiving meals to our participants the day before the holiday, but at least they were able to participate. So that's that's the level of interaction that as a program, we provide the basic necessary services, we coordinate care, we excel at coordinating care, but we also have that human touchy-feely side to how we, provide care. So I don't know what's on the next slide. Maybe you can advance the next slide. COVID response. It's been a challenge, to say the least, and I think we've been incredibly successful given the circumstances. So we do have, as I had mentioned earlier, a remote conference line that we use specifically for recreation. We actually, with one of the calls we had with one of our senior buildings, we asked them what we could do for them, and so many of their residents are so socially isolated. So our intake and enrollment team even now has a line that they can do bingo, to be able to basically show some of the positive aspects of the program, but also to help support these senior buildings in maybe giving some socialization to their residents, whether they're in our program or not. But we've been under governor's order. We're only allowed to bring participants here for urgent medical needs and rehab needs. For our transportation, our drivers and aides, we're actually competencied and trained. We make phone calls before we get to a participant's home to do the screening, and we take temperatures and pulse oximetry before they even get on our vans. We've had to close down the center, and typically we would see about 130 of our participants in the center on any given day. But I am anticipating a phased reopening whenever that would occur. And with the social distancing in the center, we're going from about a capacity of 130 participants to about maybe maximum of 40 with the social distancing. So I think that the changes not only are occurring with them being out of the center, but getting them safely back is still going to take some time. We have obviously stepped up our in-home assessments and visits, particularly with our home health aides. We've tried to institute telehealth. It's been rather unsuccessful because so many of our participants do not have the technology. Many of them don't have the minutes or whatever the case may be. We have been, early on, we were able to do a lot of telehealth with the nursing homes, so they did have that ability. But we continue to look at how we can try to implement telehealth wherever possible. I know I mentioned that we very often that we support caregivers. So, if you know somebody that you see struggling taking care of a loved one, and I think with so many people at home with the pandemic, maybe they were able to see their loved one really start to fail because they're at work every day, but now they're seeing it more and more. We're definitely there for caregivers. And we've received outstanding feedback from our families and caregivers during the pandemic. So we just continue to figure out what we can do remotely to the extent possible, and just hope and pray that at some point we're going to be able to get some of our participants back, and pray for the day that we're able to fully function again as we did pre-COVID. I know that I don't have a slide here, but I did want to speak just very briefly about our innovative approach to vaccinating our participants. It's been very challenging just trying to overcome the fear that they have. Honestly, even with flu immunizations, we always are challenged with our elderly and educating them and helping to dispel any myths that they might have about a vaccination. But certainly COVID has been even more challenging. We don't do as well with having participants really reading material. So we have a crisis telephone line with all of their phone numbers. And when we have really important messaging, we'll send messages through that line. We also did a town hall with one of our conference lines with our medical director so that she could educate. One of the things that my entire team is doing here, all of the nurses, everybody, regardless of what your role is in this organization, our participants receive a daily touch-based phone call. Just to touch base, and we know the questions to ask. But even our team making the phone calls has been given some, basic information to be able to share with the participants in an attempt to, encourage them to get vaccinated. What we did here is we collaborated with St. Francis Medical Center. There's a lot of chain of custody issues with the timing and not defrosting, but taking the vaccination or the vial out of the refrigerator for a certain period of time. And so we coordinate very closely with our transportation department. And we're down in Bordentown. Most of our participants are up in the Trenton area, and we didn't want to waste vaccination. So we dedicate 3 days a week 2 of our vans to go pick up participants. We're also socially isolating on our vans, so we only have the capacity to get 4 at a time. Under normal circumstances, we can get about 10 to 12 participants on a van, and we bring them to the hospital. The pharmacy is right down the hallway. We're able to get them vaccinated. We observe them on the van. It's been fabulous because it's a chance for participants who haven't seen so many of us to interact with some of the Life St. Francis team. And we're right now doing all of the second vaccinations. But we have had some days where participants will cancel at the last minute. We call transportation and they will go and get 2 people out of the community very quickly and get them to us to get vaccinated. So I think so many of my counterparts in other organizations, everybody's had maybe some unique approach to getting participants vaccinated, but obviously it's something on the forefront for us to try to just another measure to keep them safe living in the community. I think that's about all I have, and I certainly want to make sure that we leave enough time for any questions or comments that anybody might have.
I want to thank all of you. Thank you, Lisa, Meagan, and Margaret, for your presentations. We do have a lot of time for questions, and that's a good thing. We have a lot of questions. So again, I'm going to turn this over to Meagan, and she's going to facilitate the questions. Thank you.
Sure. Thank you again, Lisa. That was a super comprehensive presentation, and I love that you ended it on a hopeful note. It's been a challenging year for a lot of folks, so it's nice to hear about innovative and creative solutions to getting people vaccinated. As Sue mentioned, we do have quite a few questions here in the chat. I will just encourage folks to now, if you haven't put a question in the chat, please feel free to do so. Lisa is a wealth of knowledge, so I want to make sure that you make use of her time and expertise. Just going to run through them now. Will we have copies of the slides? I tried to respond into the chat. Sue said earlier that she will be circulating the slideshow presentation. There's some compliments in here, Lisa, so thanking you for the information and complimenting your program. There's one question about how many active cases and what's the geography. I'm thinking that the attendee means, how many
enrollment.
Participants.
Mm-hmm. Yep. Right now we have 298 participants, but what I will say is this time last year, we were at a census of 353. It has been an incredible challenge for every PACE program, and we are no different. We have had many, many deaths, not all due to COVID, maybe 23, but we've also had many participants who moved out of the area to be with family members because family members did not want them living by themselves. So, without the ability to continue to grow the program with all of the referral sources being shut down, it's certainly been a challenge. And I know all of my, counterparts in the state have been struggling with the same issue.
Thank you. The next question is, when do you anticipate you will offer PACE services in Bergen County? I think you addressed this in an earlier slide, but do you want to comment further on that, Lisa?
That really is up to the state. I can tell you right now, we are all waiting for an RFP to come out to cover the county of Burlington. From the many conversations we have had with the state, I think that their goal is to just take one county at a time. So I don't know that Bergen County at the moment is on their radar, but they do assign PACE programs by county or by zip code. So for example, our sister program down in Pennsauken has part of Burlington County, has certain zip codes. We have certain zip codes, but there are many zip codes that are still not served even within the county. I'm not sure if Bergen is on their list yet, but that would be a question more for the state.
So there's quite a few funding questions. So I'm going to try to group 3 or 4 together, but there's some questions on how PACE programs are paid, how are you funded, and how much does Medicare and Medicaid revenue match the expenses, and how do you make up the difference?
Wow, that's a great question. And it's a loaded question, so make sure I don't forget anything when I'm answering, Megan. So as I had mentioned earlier, we have a 3-way contract with Medicare and Medicaid. You have to have the ability to pay the Medicaid premium. And otherwise we get capitated dollars. So we get a certain capitated level for somebody who's dual, meaning they have both Medicare and Medicaid, or if they have just Medicaid, it's a different capitation. For Medicare, there's different factors. The way we code, there's something called a hierarchical coding category. There's a survey that comes out every year called an HOS survey, where a frailty score is determined. And that also factors into a risk score. And that's really it's really individualized for each of our participants under Medicare. So unless something changes to Medicare's rates or to our risk score, every participant pretty much gets the set amount every month that gets paid to us. We also have Part D, so we put in a bid every year because we provide all of the medications in the program. We have a very robust compliance program because we do provide the medications and have the Part D oversight. I don't remember what the last part of that question was, if I covered everything.
I think you did. Yeah, I think you covered it. So the next question is, are PACE center services available during the pandemic since most centers are closed for now? I think Lisa addressed that. The governor did issue an executive order, so her center, I know, is open for urgent medical and rehab needs, and she anticipates a phased-in return to the center. The next question is about enrollment and how did COVID impact your enrollment for PACE? I know you spoke about that earlier, Lisa. I'm not sure if there was anything else you wanted to add, or if you'd like me to just move on to the next question.
Yeah, no, I think I addressed that through, having our referral sources pretty much shut down and whatnot. No, I think I answered that. If I didn't, then maybe somebody can just put it back into the chat.
The next question is, how stable or variable is the number of participants over recent years before COVID?
We had a great track record. I mean, we did not have many disenrollments at all. And usually if somebody disenrolled, it was, maybe the majority of the people that would disenroll, maybe they just want to be able to expand the network of providers. I mean, we become the primary care provider, our team here. So many, and that's oftentimes a barrier to enrollment as well, because many of our prospectives participants do not want to give up their primary care provider, or maybe they see a certain cardiologist and we don't contract with that group. So we try to find ways to overcome that. Yeah, I think that I fully answered that.
Yeah. The next question, once again, I'm going to try to combine a couple of them. There's a few caregivers, loved ones who are looking for assistance for their loved one. One person's in Ocean County, one person's in Essex. They're wondering if there are PACE programs in those counties.
Yep. The best thing to do is really to do a search for the state of New Jersey PACE program, because the state has a whole website and they will list all the programs and the zip codes that they cover. Or you can go into, if you get a copy of this presentation, there was one slide that had all the different programs and where they're located, and you go directly into their website. each of us has the zip codes listed that we cover, but the state is probably the most comprehensive site where you'll get all that information.
Okay, the next one is a comment question. As such a comprehensive care model, can you talk a little bit about how your approach working with prospective new technologies could help improve the outcomes at your organization?
Well, you know, really the best technology right now that we could certainly employ is anything that is, you know, telehealth related. There is a company that our corporate office is looking at, and we may become a pilot site where it's a contained unit that has the internet contained in the unit where we can do video with the participants. So we could maybe select certain participants that are maybe high risk or who are always calling the answering service or who really need a lot of support in the home. And that's a barrier because so many, not only with the phones, they just don't even have access to the internet for us to be able to do that. So we already have an electronic medical record. Being in the Trenton area, our medical director has access through the Trenton Health team to medical records if they were in the hospital for, you know, our participants. So we try to leverage technology to the extent possible, but the telehealth has been our biggest challenge. And if we could get something really solidified with that, I think it would really, you know, solve a lot of problems with access and support.
Okay, thank you. The next question is, hold on, I just had it and then someone put something in here and it changed the chat. Do you have a Part D rebate program and how does it look like?
So that was the bid that I talked about every year. So it's basically based on some of your historical data. I mean, my director of finance spends many, many weeks pulling the bid together with the company who consults with us. And we submit the bid to Medicare. And then based on the usage, there's a reconciliation at the end of the year. If we spent under, then, you know, that money, you know, the adjustments are made for the unders and overages, let's put it that way, at the end of the year. But we go through this process every year, you know, based on the information that we have.
Great, thank you. The next comment or question in the chat is from Maria DiMaggio from the New Jersey Housing and Mortgage Finance Agency. And she mentioned that they will be working with the Life St. Francis program by funding a VOA-owned senior building in Bordentown that will incorporate PACE services. And she mentioned that she would be happy to work with you in educating senior buildings in your service areas about the PACE program.
Oh my gosh, well, that's outstanding. And I hope my contact information is in the presentation. If not, then I'm not really sure. I mean, just call our main number or ask for me, but absolutely, that sounds like a phenomenal opportunity and I would love to pursue that with you.
I can share it with Maria.
Thank you.
You're welcome.
Are there any other attendees that have questions for Lisa, Margaret, Sue, or myself? Okay, there's another one that just came in. If the capitated payment is $5,000 per enrollee and the actual cost is $1,000, does it mean the agency can keep the difference?
Well, you have to understand the whole foundation of being a risk-based program. We get the capitation, and you just never know how somebody's care is going to progress. So when I had said earlier that we really take care of participants throughout the continuum, I mean, somebody might come into the program, be perfectly fine. They fall, I used the example earlier, they break their hip. Now we're going to be paying out a claim to the hospital. We're going to probably have a lengthy rehab stay. And then maybe they're going to need more supportive services in the home. So it's not a matter of keeping, it's really just this is the funding that we need for the IDT to be able to really do a phenomenal job at providing the care and services, because the needs change, based on participants and what's happening in their world. So, nobody can really predict what's going to happen. So that's really there in reserve to be able to take care of our participants, regardless of what their needs are.
Great. There's another question about someone who's in the early stages of researching for long-term care. How do they get more information and site visits? I see that Margaret responded to them in the chat, so thank you, Margaret, with her contact information. I'm not sure, Kevin, where you're located, but I know that the center is currently closed, but I don't know, Lisa, if you could talk a little bit more about, caregivers who are interested in, do you do site visits of the PACE Center? And how do they get more information about, their program if they're interested in looking into that for their loved one?
Yeah, right now with the center still being closed under executive, typically, yes, we would absolutely do site visits, but we're really being respectful of the executive order, but also trying to keep our colleagues and staff here that are working in the building safe. So we've not been doing as many or any tours, but our intake and enrollment team will come to you. We have on our website for Life St. Francis a great video. It shows you some of our center. I think there's actually 2 videos out there, so you can get a feel for what the center looks like. What unfortunately you can't see is what it looks like in action when we do have a full center, and all the life that's happening here at Life. But our main number is on our website, but if you're writing it down, 609-599-5433, and you just need to ask for our intake and enrollment department. We have phenomenal colleagues that work in that department that are so well versed in the program, and would be happy to connect with you.
Thanks, Lisa. I just put the link into the chat that Lisa was referring to earlier on the state's website, where it not only lists the PACE programs, their contact information, and their geographic service area, but more specifically, the zip codes. So for any caregivers on the line that are researching options for their loved ones, you can look there to see if PACE is currently in your zip code. And then I know there was a couple of questions about our contact information. So I think, Sue, if you could take the lead on just circulating Lisa's email and phone number, mine and Margaret's, to anyone who registered. I'm happy to make any connections and follow up with questions afterwards.
Certainly.
And with my phone number, please feel free to leave a message. I'm oftentimes not available or in meetings. Email is probably the best way to get hold of me. And then we can, if we need to, we can connect by phone.
Great. Are there any other questions, comments from anyone else who participated in the webinar? Lisa, folks are asking for your email. I can put it in the chat if
I can just tell you what it is. I mean, if you're writing, it's my last name, Zavorski. So L, Z like zebra, A, V like Victor, ORSKI, at ST Francis Medical. It's all one word, no period after the ST, and Francis with an I.org. So L Zavorski at stfrancismedical.org.
I also just put it in the chat for folks that want to copy and paste. Well, thank you so much. I thought this was an amazing program. Thank you again. If there's any other questions or comments, we have a couple minutes. Otherwise, I'm turning it back to Sue.
Thank you. I can't thank you enough, Lisa and Meagan and Margaret, especially for Parker for their sponsorship. On your screen, you'll see now the next webinar in this Programs and Innovations series. So please mark your calendars for April 13th. There will be more information coming. And I also wanted to let you know that NJAAW will be holding its 23rd annual conference on June 3rd and 4th, and more information will be coming about that too. Do any of the speakers have any other information to share?
I don't, but thank you everybody for being patient with me and letting me go on and on. I hope you found some value from the presentation.
And thank you for all your questions. We had 40 something questions in there.
That's
and comments,
great.
and
That's great.
we really appreciate it. I think it just shows that there's a tremendous amount of interest in PACE. And we're
Yeah.
so glad that you could be our speaker, Lisa. Thank you so much. And again,
Oh, you're so
Meagan,
welcome.
thank you. And Margaret, we appreciate your sponsorship. Okay, we're
Thanks so
out
much.
a little bit early, everybody. So enjoy the rest of your afternoon and week. And we certainly appreciate your participation. Have a great day. Take care, everybody.
Take
Bye-bye.
care, everybody.
Thank you.